Welcome to another episode of Talk on Things and Stuff. Today, we're going to talk a little bit about a documentary that I recently published to my channel. And I want to speak a little bit about why this documentary is important. Now, if you've been following the channel over the past several months, I've been publishing the recordings from the hearings of various states as they've received feedback from concerned parents and from patients about the way that children with gender dysphoria are being cycled through the medical system here in America. In Florida, this took the form of hearings at the state medical board. In Missouri and Ohio, there were hearings held in the levels of government. And in each of those different cases, they asked both experts stateside as well as some international experts to come and answer questions and to present information both for and against the way that children with gender dysphoria are being treated here in America. And you'll notice if you follow some of those discussions that the question of why is it that certain countries in Europe who have been doing this type of therapy for children with gender dysphoria for several years longer than America, why they're putting the brakes on it, why they seem to be changing their course and reversing their policy of the affirmation-only approach. And it's interesting when you see those moments where either a senator or a representative asks the expert, why is Europe putting the brakes on? Why are they saying, hold on, let's slow down, let's not be so hasty, when here in America, we're trying to fight people who are saying, slow down, wait, let's not do it so affirmative only. And in some cases, the experts are like, well, they have their reasons, but we don't really know. And it's controversial, it's political or something, but there's no clear, concise sense of why some of these countries who have years, if not a decade or more experience treating more patients are deciding that it's not the best way forward. And it seems like it would be a really important thing to know because we can kind of benefit from their experience. They've been doing it longer. If we can learn why they would put the brakes on it, we can understand better how we could navigate our own ventures into that area of therapy better. And so it got me thinking, we need to know more about this, but it's hard to find about this. I've read several books on the issue, including some that I would highly recommend, including especially the book by Helen Joyce called Trans: When Ideology Meets Reality. And she covers some of these political issues as well as the evidence base of it. And it's mentioned either in her book or in some of her interviews how in Sweden in particular, there were a series of documentaries that had a powerful impact in waking people up to what was going on in the arena of care for patients with gender dysphoria. And though the effect of that documentary led to them eventually kind of changing their policy on how they were treating these kids. And so that kind of sparked an idea where we need to see where that documentary is, how can we have access to it to learn what they had. And I found it, but it was only in Swedish language. And I was able to locate a version that had subtitles, but it's still kind of hard to access. It's hard to take that in when you have to read the screen every time. So I went ahead and removed the Swedish voiceover and replaced it with myself doing the English narration. That way you can kind of put it on in the background, listen to it, and maybe take it in a little easier. And that was what was published on this channel earlier today. And I published it with the invitation for people to watch it and then be open to call in and share some of their thoughts and perspectives on it, both either for or against. Because again, this is a highly contentious issue. There are people with really strong feelings on both sides of this. And you have the extremes on the people who are critical of it, who say that the entire thing is the result of some sort of cult mentality and that no people, regardless of their age, should ever be allowed to transition. And then you have people on the other side who say that, as soon as somebody determines that they are trans, then there should really be no gatekeeping at all in terms of what changes that they want to make to their body, and regardless of what age, within, reason. And kind of navigating where the right balance is between those things is what all of these countries, what America, what all the states are trying to do. But in the midst of all of that discourse, you have the medical profession. And the medical profession is supposed to be rooted in evidence base and rooted in ethical principles, so that when we explore new therapies, we don't simply find a new technology and decide that we want to use it. We have to be very careful in which patients we apply it to. We have to have a good base of evidence that our therapy is actually going to help the patient and that the benefit is going to outweigh the side effects or the risks. And we have to make sure that once we do a study to determine if a therapy is effective, that when we apply it then to a wider population, that we're not doing harm by misapplying something that we learned in a very narrow population by applying it to a larger population that may include patients that don't have exactly the same profile. It's very different when you deal with gender identity versus something like a cancer, where you can do tests to get a very specific genotype of cancer, know exactly what it is, and then you can tailor the therapy to it. When you talk about something like gender identity, then you're talking about things that have to do with somebody's psychology, and it's not as easy to narrow down the exact patient population that you were applying a therapy to. So with all of this being said, I know many people didn't get a chance to watch the documentary. I've selected some clips that I think are important to discuss. And again, this is I think it's now a 4-part series. And so I'll be releasing each of the different 4 parts and hosting a call-in discussion between them. So in the meantime, I want to go ahead and put up our call-in banner. If you have something to say about this issue, if you had a chance to watch the documentary, then you can call in 210-422-2222. If I don't answer, it may be that we're in the middle of a particular discussion or I'm already talking with someone. Just hang up and try again when the time is right. So in the meantime, we will go ahead and start. If you haven't had a chance to watch the documentary, it starts out with a story of a detransitioner, and it's through the lens of detransitioners that you really start to peel back the layers of the onion so you can understand what has gone on as the therapies have evolved over time and where the medical profession may have some deficiencies in the ethics and evidence base of how it's being applied. So I want to start out with going to the story, the transitioner that the documentary is framed around, and it's a young woman named Samedi. And when you're first introduced to Samedi, if you're not familiar with detransitioners, it'll seem a little bit jarring because you're going to hear a voice that sounds very much like a man's voice, and you're going to see someone who has a lot of the facial features of a man. But as you learn her story, you'll understand how the medical therapy produced this affect to how she looks and how that has changed with her psychology over time and how she sees it differently now. So let's go ahead and share that screen. And we'll go to Samedi's story and bring it here. Okay.
I have been having gender dysphoria ever since I was a kid. And I had been thinking about my gender identity for years. And when I heard about transgenders, I was like, instantly, I was like, so this is what it is.
Now, what she just described there, where she was having a lot of dysphoria, she was feeling uncomfortable with her body and was trying to make sense of it, and nothing seemed to make sense of it until she came across the concept of gender dysphoria. When you talk to or listen to detransitioners, you'll see that that is a very common theme in what their entry point was into detransition. This is specifically the cohort of patients that were a little bit older than a toddler or a very, very young child when they first were introduced to the idea. And it's that seed where you have usually adolescents who feel uncomfortable in their body and then find this potential answer that seems to explain everything that then they latch onto, that people who are concerned that this may be something altogether different from somebody who has some innate sense that they're born in the wrong body. It seems to be something that can be influenced by both social contagion, information that you're exposed to on the internet, and kind of social dynamic forces. And you mix that in with the feeling that many teenagers have as they're going through adolescence, as their body is going through puberty and starting to change, and they're starting to have to confront some of the adult issues that they've never had to as a child. For young women, that can be both the development of the secondary features of womanhood, whether that's breast development or the menstrual cycle starting, as well as attention that is unwanted and unfamiliar from men. And you mix this in with people who may have a history of sexual assault or sexual abuse, and you have very complex psychological situations that may end up in somebody identifying as trans or seeing something in wanting to see themselves as something other than a normal woman because they don't see themselves as fitting what is portrayed as a quote unquote normal woman in society. And so this is a set of ideas that they can hold on to that seems to make sense. That notion, everything that I just described, is something that if you start talking about this with people who are very, very closely tied to the general discourse in how transness and queerness are portrayed in social media, you'll get yourself in trouble. People will say, well, no, that's actually a hateful set of ideas. You're misattributing something and you're setting up a platform for bigotry and hate. And, trying to balance that perspective with the experience that these people have once they go down this pathway and eventually decide it's not for them. It's a really complicated decision, and it's not as simple as simply calling one thing hate and another thing ignorance or indoctrination. So let's keep going. Again, if you want to call, you can either leave a comment in the Facebook or YouTube, or call 210-422-2222 if you're here in America, and call in. All right, here, let's keep going.
I'm female. That is what I am. I felt that there is something different in my brain. It has always been present in my life. So when I learned about transgenderism, I felt that I just cannot go on anymore, so I had to change myself. It went on for a very long time. Like it took months. I don't know how many meetings. I started the hormones in, if I remember correctly, I started 2012 on May, and my first surgery was December 2012. And it was the breast thing. It felt good. I felt that this is the solution. Yeah. Like now we are doing the thing that will fix me. Like when I do this, I will not feel bad anymore because this is the thing that I need to do. And when I started to see the changes, I felt that like, yes, like now it's happening. Like now we are getting better.
Samedi lives in Joensuu in eastern Finland. She has decided to speak out openly for the first time about what happened. She's not alone in her story, particularly in Sweden. But few dare to talk about it.
Because I cannot hide anymore. Because, everybody can see what I am. I sound weird, I look weird. And whenever I go to a bathroom or stuff like that, if people hear my voice, they think that I'm a male. Like I'm a guy in a dress who is coming to a women's bathroom or a women's locker room. And there have been people who, I have been to a grocery store or a place like that. And then there's somebody next to me who is like, are you a man or a woman? When they just hear my voice and they are like, oh my God, what are you? I had a lot of problems.
So a couple of things that they just covered. First one is that she mentioned that she had to go through several months of therapy in spinning up to be able to qualify for the surgeries. And this is one of the points of contention that comes up frequently when you listen to the hearings here in the States of them trying to either prohibit or protect the ability of doctors to treat children with hormones and medication. One of the arguments is, well, a patient went in and after just a 15-minute meeting, they were given hormones. And then people who are trying to defend the practice say, well, that's a misrepresentation. That doesn't actually happen. It takes months and months in order for it to happen. And the reality is, if you accept some of these stories, is that you have hundreds of clinics implementing these therapies, and it's not all done uniformly. And there are some clinics that, for whatever reason, the gatekeeping is very, very minimal, and people have access to hormones with a minimal degree of meetings or times going in. And there are other places where they're much more rigorous in terms of doing digging deeper. What's important to keep in mind, though, is that when you go and ask all of these clinics, well, how do you design your process for introducing this therapy to someone? They'll say, well, we follow the guidelines of the Endocrine Society or the American Pediatric Society or the WPATH Society. And each of those things, kind of the American Endocrine Society, all the other professional societies will point to WPATH. And when you read WPATH and you look at their guidelines, they're based on something called the Dutch protocol. And this is for treating adolescents, particularly who have gender dysphoria. And so that Dutch protocol becomes the focal point of how this treatment is being applied to the population that we're seeing now here in 2020 through 2023, because the Dutch protocol had exclusion criteria. You could not get the puberty blockers or the hormones or the surgery if you were in the category of patients that we're seeing mostly today, which is people that are discovering or coming to the notion that they are trans or have gender dysphoria as teenagers. This is, if you are strict in the Dutch protocol, it has to be people who have presented very early in their childhood. On top of that, you can't have any comorbid psychiatric conditions. So if you have someone who is depressed and anxious, who has anorexia, who has other significant mental and psychological disorders, well, they wouldn't qualify for that because they excluded any patients for that. So it's a very specific profile of the patient that they applied that to. And the thing that doesn't get discussed too much in those hearings is whether or not they're applying the same rigorous exclusion criteria that the Dutch protocol had. Because even though the Dutch protocol is being used as the rationale for saying, hey, this works, if you don't apply the same exclusion criteria, then you're actually applying this therapy to a completely different cohort of patients, and you can't extrapolate success by the Dutch study on a very specific type of patient to a completely different patient set who may have a completely different set of underlying comorbid psychological factors that are in the mix of their decision and their experience of gender dysphoria. So the question of the Dutch protocol will become much more important as we see later issues of this documentary, but that's just something to keep in mind. The next thing that she covered was this experience where she's going through life now as a detransitioner and is having a whole new set of challenges where people are perceiving her as masculine, and she has to reassure them, or she's confronted with saying, no, I'm actually a woman, when people are saying, wait, you sound like a man, you have masculine facial features, what are you doing here in this bathroom? And that's a challenge that a lot of detransitioners are speaking about. And in most of the cases where they've gone as far as this particular patient, where they've had surgery and years of hormone therapy with a significant effect to their voice, their muscular build, their facial features, those things are essentially irreversible, and they're going to have to navigate them for the rest of their life. And when you read books like Abigail Shrier's Irreversible Damage, you can start to understand a little bit more the nature of the effects of these therapies, how it's different from normal adolescent identity navigation, where you try different identities on and you gradually integrate all the different facets of your psychology into who you are when you become a young adult. most of those identities that you try on and you experiment with don't have irreversible changes. And so you can try them on, keep parts of it, and navigate. When I was a kid, there were many different ways of being and ways of identifying that people could try on, but they didn't involve surgical manipulation or hormonal manipulation of your body that could not be reversed. And it's kind of blending that normal adolescent process of navigating identities to integrate your own with these irreversible changes that is causing people to say, hold on, we need to be very, very careful about who we do this. Because if we broaden the population that we apply these therapies to, we inevitably are going to include patients who would not ultimately settle in that identity and would maybe try it on for a little bit and then decide it wasn't for them. When you bring that up, people will say, well, you're dismissing and minimizing the real lived experience of trans people. And that's kind of the crux of the question, because a lot of detransitioners will say, as soon as they detransitioned and they started to talk about it, then trans rights activists will say, well, you were never trans. You were never really trans. You were just a messed up kid. And even if you want to accept that perspective, then that still points to the medical profession having a problem in that they can't distinguish messed up kids from real trans kids. The reason they can't distinguish that is because the affirmation only model specifically says if you start to ask questions to get a bigger picture of the wider psychological landscape that a child is going through, with the possibility that they may be a messed up kid, quote unquote, rather than somebody that, would be classified as true trans if you knew the end of things, then how are clinicians able to do that? The gender affirmation only model is a machine to produce detransitioners because you're not able to select patients in the same way that the studies that were used to justify the therapy in the first place were. And the Dutch protocol is important to understand, not only for how its claims are being inappropriately adapted to the current population of patients, because the patients that they would have excluded are the very patients that it's being applied to now. But if you dig deeper, you find that the claims that they made about its success have some serious problems as well, but that'll be the subject for another episode. So again, you can call in at 210 422-2222 if you want to share some of your perspective or maybe your own experience in navigating this question. But without any calls, we'll go ahead and continue with Samedi's story.
With my emotions, I had lots of emotional problems. I call them emotional locks. Like I had lots of locks. It made my disconnection to my body even worse.
When you first started the treatment, can you explain how it felt for you?
Good. That is a bit scary, I think. I had a pretty bad dysphoria, and the treatment did take that away. I felt good. I think that I looked better. I liked my new figure. When I look at the old photos of myself before I started the treatment, I look a lot different from the face.
Okay. This is actually a fairly important point to cover, and that is the fact that even detransitioners who have ultimately come to the decision that it's not the choice for them and that it was a wrong choice for them, or that maybe it was the right choice at the time, but it's not the choice now, they'll report that immediately after they started taking testosterone or immediately after a surgery, they did have a rush of euphoria. They had positive feelings and an improvement in their gender dysphoria as a result of those therapies. And that experience is real. And people have looked back on that when you ask them, well, why do you suppose that was? And some of the things that you'll hear them say is that, well, testosterone itself is a controlled substance because it has effects that may manifest as euphoria. For a young woman who has never experienced those high levels of testosterone, it can make them feel empowered, it can give them energy, it can do all these different things that they are unfamiliar with because their natal biology is not used to having that level of testosterone. And so it can have that experience. I think there's psychological forces at play as well, which is that if you've been saturated in social media content talking about how good you will feel once you make that transition, and it's a transition that's tied to the very things that are making you feel dysphoric now, then in the short term, you are going to feel like there's been an improvement because some of the things that you've identified as the source of your problem have changed. And then the question is, well, is that feeling of positive outcome, is it permanent? Is it now you will live the rest of your life and you'll not have any of those issues? And that's where long-term studies following the same patients over decades of time become very important. And one of the data points that has made the biggest splash is in these countries who have nationalized healthcare systems so that anyone who gets therapy is going to government medical facilities, and they have unified record keeping where they, one clinic sees all the trans patients. And so they have records spanning decades of everyone that received those therapies in that country. Well, they're the best places to get the longest term data on it. And so in Sweden, where they have the longest reported data on, in this case, the suicide rate, it's frequently brought up in the hearings that the suicide rate of those trans patients is 19 times greater than age-matched general population. And that's concerning because a lot of the times the justification for getting these therapies is, well, you don't want to have a dead daughter. Wouldn't you rather have a live son, and use that as the justification for it? And so they'll say, if you don't transition, then your child will commit suicide. But if their suicide rate remains 19 times higher than the general population after 30 years, you've got to be very careful about whether or not that justification is legitimate. And you can't simply use that 19 times higher rate as a hammer. You have to say, well, is that the same as, because that's matched with the general population. A better match would be if you matched with people who also had gender dysphoria but did not receive the therapy. Is their suicide rate higher or not? And so because that is an empty box that hasn't been answered, people say that you can't use that 19 times statistic at all. And I think it's a little bit more complicated than that. And that's when you look at the desistance rate. But that's, again, the subject for another discussion. So we've got a few comments. And before we continue, let's take a look. Let's see, Jack says, thanks for starting the conversation. Have you seen any differences in the reception of your coverage of this topic amongst your existing audience? Now, my primary audience is generally those who are ex-Mormon or members of other high-demand religious groups. And if you've ever been in ex-Mormon communities, you'll see that there is not an insignificant number of ex-Mormons who have family members who identify as trans, and some of whom have pursued hormonal and surgical therapy for their kids. And so it's one of the things where I felt like I wanted to apply the same sort of examination and understanding to this issue that I had to apply to my religious tradition when I tried to figure out what was real, what was not real. And so when I started asking these questions, I got a little bit of pushback. I would post in the usual forums where if you post anything about, the prophet Joseph Smith, anything that's critical about it, you'll get a great deal of applause. And people will give you a pat on the back and say, yeah, that's great. But if you start questioning the wisdom of affirmation-only therapy, then you'll get some pushback. And I've had people say, well, you have no business asking these questions. You shouldn't be exploring this. It's actually kind of hateful and bigoted for you to even suggest the possibility that there's a social contagion component of it, and you need to educate yourself. And so, it's hard to navigate those things. I think overall, there's been some reception to having the discussion. Of course, there are people who are very strongly invested in one position or the other, and I don't see them as bad. I see them as having very good reasons for feeling the way that they do. And it can be scary if you've taken drastic steps with a loved one or yourself. It can feel kind of threatening to be exposed to information that is different from what you accept and hold true. And it's kind of similar to sort of the feelings that faithful members of the church had, where they felt very strongly about Joseph Smith being a certain way, and it feels threatening to hear information that runs counter to that. And so that should be a familiar feeling of, if the information that I would bring up in a conversation is false or wrong or true, you should be able to kind of investigate it and see that it's false or wrong or true. And it shouldn't really be something where you would want to shut down the conversation. Now, if somebody came into a conversation saying that, no trans people have any experience that's worth giving any credibility to at all, and that there's no such thing as the experience that people have as trans, and that it's all simply cult indoctrination, you're not going to make much headway in that way, and it's not really a good way to hold a conversation. And I don't think it really bears true in reality. I think the reason that some of these things exist is because there are people for whom these changes in their life are life-saving and become the way that they pattern their lives after it. But it's kind of a difficult thing to navigate when you see how we implement those therapies. So thanks for the question. I guess my biggest fear is that people are going to be, non-Mormons are going to be like, what is this Mormon guy talking about this? Is he just trying to convert me to the church? This is not a Mormon channel, and we don't try to convert people to the church. The church is not particularly happy with this channel, I would think. And then for people who are on the Mormon side of things, it may be just something that you don't want to have to bother with until you're confronted with somebody in your family and your loved ones in your friend circle who come out as trans or are experiencing gender dysphoria. And then I think there's more incentive to at least understand a little bit more about it. There's plenty of information out there about the pro-trans perspective. It's harder to find information that gives the other side of the coin. And so that's kind of what I've tried to do, is just say, is there other information out there? And are we able to talk about it? One of the largest ex-Mormon podcast groups is the Mormon Stories podcast. And they have a tremendous following with literally millions of views and hours. And they've had several episodes where they've interviewed trans people, but they've never interviewed a detransitioner, and they've never covered the subject of detransition. They've never delved into the philosophical foundation of queer theory and how it has colored and shaped the current discourse about gender dysphoria and transition. And so that's something that I think it's worth understanding, whether you agree with it or disagree with it. And that's what I've tried to venture into. So, okay, let's see. And I says, I think this has been a trend in slow crescendo for 5 or so years. It takes about 3 years for hormone therapy to do the real damage. So that wave of transitioners will become a wave of detransitioners. I think there's some very real truth to that. And that's where the experience in Europe is important, because they are several years ahead of us in applying this to a broader population. And so if they're seeing a wave of detransitioners and reversing course, then we should be paying attention to that so that we can save doing unnecessary harm to that group of patients that are getting therapies that ultimately they should not be getting. Because despite, the Tumblr and Twitter people saying that there should be no gatekeeping in medicine, gatekeeping is just another word for appropriate patient selection. And if you're going to do evidence-based medicine, you have to only apply therapies to patient cohorts for whom it's been established that you can have a productive outcome. And if you end up taking a protocol that is designed for a very specific type of patient and you apply it to a much broader population of patient, then you are going to misapply that therapy to that cohort of patients, and you're going to produce what is called iatrogenic or medical system induced harm to those patients. And that is the reason that those countries are reversing course. So we just wait for it. And here in America, the other thing that will change is that you'll start to see the lawsuits come, where it's clear that the doctors who are applying this would have very little ground to stand on if they had a competent medically informed person that would say, well, you're implementing this protocol, you're basing it on what, and are you using the same, criteria for it? It gets shaky once you go and start digging into it. So, do I have any theories as to what is driving all of this? This question is asked a few times in some of the hearings from the various states, and I think it's complicated. People have said that having the susceptible group of young kids trapped at home because of COVID, being exposed to more and more social media, coming across really polished influencers in the trans space. You can go out there and find some young people who have undergone hormone and surgical transition and document their journey in TikToks and in YouTube and speak a lot about how great it is. And on top of that, there's a stigma against showing the bad parts. There's a channel by someone called Exulancic who she's found clips of people who do venture into talking about the complications of the surgeries, the complications of the hormones. And one of the things that you'll note is that when a surgery goes really bad, the person who talks about it expresses like, I don't really want to talk about this. I've tried to avoid talking about this because I don't want to dissuade anyone from taking the step to do the surgery. Or I don't want to mention the doctor's name because I don't want to scare people away from getting the surgery when, if these surgeries are having high rates of complication, that's kind of something that people need to know about. And it should be part of what children are exposed to. If they're going to be exposed to, this issue, they need to know both the good and the bad. But just the way that social media forces work, they don't want to show the bad. And so people are getting a distorted perspective on what this actually is. So I think social media plays a role in it. It's when you have a set of options, when I was a kid, the menu for different identities that you could inhabit as a teenager included things like goth, punk, roper, skater, doper, church dude. Like there were a bunch of different things. There really wasn't non-binary or trans. And that is an option now. And that's not to say that non-binary and trans are the same as skater or roper or whatever. But when you're a teenager and you're trying to figure out your life, you feel bad about your body. The non-binary and trans do have something to say about what it means when you feel bad about your body. And so you'll listen to very, heavily curated channels of social media influencers talking about it, or you'll be involved in Tumblr threads where people will talk about how they felt uncomfortable in their body, but once they realized they were trans, then it all made sense. And so you'll start to test those ideas. And in some cases, you'll find that might be a good solution for you. So if you didn't have that item on the menu, you may not have ever explored that. And some people will say, well, it shows how our society has grown as people have the freedom to do that. And that may be true, but it's also going to incorporate people who are on that journey of trying out different identities. And anyone involved in adolescent psychology knows that those identities should be something that you're free to move in and out of and without permanent changes. And if you prematurely latch on to an identity and then close off all other possibilities while you're going through that adolescent maturation process, it's a process called identity foreclosure, and it can have many different causes, including family pressure, religious pressure. But this is another instance where once you have hormones and surgery and really strong peer support in the form of the love bombing that comes with it, but also kind of the stick as opposed to the carrot, where if you decide it's not for me, then there's negative consequences of it socially. It's a strong, powerful force for identity foreclosure that gets people locked into this way of being. So it's one of the reasons why a researcher named Ken Zucker has said that even something like social transition is a type of intervention, because when you compare patients who used to have, as kids, the watchful waiting approach, where if they start to have a gender dysphoria, you talk with them, you undergo exploratory psychotherapy, but you don't treat them as the opposite gender. You don't change names, you don't change pronouns. And that when you take children who initially present with dysphoria and follow them, anywhere from 60 to 80 to 90% of them will eventually desist. But if you do socially transition them and then go onto hormones, much lower percent of them desist and they go on to those further steps. And it just shows that that is an intervention of some sort. Okay. So I'm going to let this play a little bit more and grab a glass of water because my throat is dry.
Face. It's like, you know, when I had forgotten what I looked like. And then I looked at the photos and I was like, oh my God. And I actually have some photos I can show you.
Yes. I would love to see the photos.
And now? Yeah. Can you see?
Mm-hmm.
So here.
Yeah.
Why did I ever feel the way I felt? Like I don't understand.
Yeah.
So here. So this is me before I started any hormones.
Ah. That you look different from...
Yeah, from the face. I always thought that I'm very ugly. But now that I look at myself, I never was ugly. Like, why on earth, why did I feel that I'm ugly in the first place? How did it start? It makes no sense. Yeah. Do you want to see more? Yes.
It's really interesting, that experience of I thought I was ugly, and now I look back on those pictures and I just don't understand why I ever felt that way. I think a lot of us going through puberty have that same experience of looking around and seeing everybody and assuming that everybody's all well put together and they're feeling fine. We're the only ones who are really uncomfortable, don't like the way that we look, don't like the changes that are happening, because everybody kind of curates what they show the rest of the world. So you know all of your ups and downs, but you generally tend to only see other people's ups. And so you judge yourself harshly, you think poorly of yourself, and it takes a lot of time to navigate through that and to have a broader, wider perspective. But if you're given these answers for what that means and what you should do about it, then it may change your trajectory. And certainly for this patient, that's part of their story. So let's see. If you want to share any of your perspective on any of these issues, you can call 210-422-2222. I would love to hear from anyone. We have a comment from Christopher Rice. Should we transition kids who identify as mythical creatures in fiction? That's the type of argument that when you engage somebody who has a strong opinion on this, it will seem like you're making a good point. And it's from a strictly logical perspective, you could say that is a good point because you've said that the things that they're identifying as are outside of the bounds of reality. And so you're giving another example of something that is outside of the bounds of reality and holding that. And the response that you get when you talk to clinicians who face these patients is, regardless of what you think about the reality of whether or not someone can be born in the wrong body, whether or not that's a real experience, whether or not that's a social contagion, whatever it is, the thing that is real that you can't really argue with is the distress that it's causing the person who's sitting in front of you when you're a clinician taking care of that. And if you are faced with someone, whether it's your own child or a patient, if you're a clinician who's expressing this distress, if you respond to them and say, well, you know, you can't identify as a unicorn, so why are you identifying as a girl if you're really a boy? You're not going to make any headway. It's not going to be productive, and it's not really addressing the issue. The issue is the distress that they're feeling and how we can respond to that. Where the debate comes is, do we see that as a problem in the mind that can be addressed like other problems in the mind, like depression, like anxiety, like body dysmorphic disorder, where you engage in exploratory psychotherapy to try to understand the landscape of the person, other things that have happened in their lives, perceptions that they have, ways of dealing with challenges that they have, help them understand themselves better. And in some cases, that exploratory psychotherapy can change the way people perceive their body or the way that they understand the distress that they have. And in some cases, that distress can resolve. And that's historically how the watch and wait process has been undergone. Now, that's not to say that watch and wait will always resolve it, because there are patients for whom that process does not resolve it. They continue to feel the distress. I think that's where using the mythical creature analogy is not really helpful, because there are going to be patients for whom this will be a solution for them ultimately. The question is, do we sacrifice the larger number of kids who would ultimately desist in order to save the small percentage of patients who wouldn't have desisted, save them from going through puberty? That's the big question on this issue. And it's a little bit of a trolley car question, but I've got an episode planned for that in the future, so we can kind of understand that question in the future. So your point, Christopher, I can understand it from a logical perspective, but if you are confronted with a child, for example, who experiences this, I would hold that argument back and be more curious and explore a little bit more about what it means to them, what it is that's behind their distress, how it affects their life. Okay. Anais presents some ideas for why this is being so prevalent nowadays: lack of role models, derealization caused by living chronically online, no real life goals, unable to reflect on big life changes, unable to reflect on mass hysteria. Some of those may be the effects of the distress that are happening here. I think the lack of role models, one of the things that we may be faced with more of a challenge now that wasn't there in the case, particularly of young women, is having strong social connections with older women who have been through some of the challenges of adolescence and puberty, women who there's a strong foundation of trust for. So when the younger women start to experience some of the distress over the changes of puberty, over navigating a world of sexualization and expectations of women, if they had good, strong role models that they trusted that could normalize some of these experiences and say, hey, this is something that affected me too, but we've got a whole group of really capable, strong women who've gone through that process and navigated it, particularly in view of the fact that a significant number of the patients who experience this end up being lesbian, if you're talking about the young women, or gay if they're the young men. And there's a concept called transing away the gay, that people are noticing that of the younger generation that has the ability to identify with the opposite gender, in past years, they would have grown up as gay men or lesbians. And this is kind of decimating that population. And so some people see this as a sort of genocide of young gay people, or they're sterilizing young gay people, because many of these therapies are essentially sterilization. These people will never have children on their own because of either surgical castration or the effect of long-term wrong sex hormones on the reproductive system of the body. Okay. Okay, so let's keep going with our story here. We have just a few seconds left.
I had pretty bad dysphoria, and the treatment did take that away, but it didn't solve the problems in the long run. I think the first 2 years were very good. I really like the strawberries. Regret was not supposed to happen. And where am I now? My problems still exist. I still haven't found a solution to them. Nothing can be done about my body anymore. because the surgeries and everything, they are irreversible. My voice is always going to sound like this. I will not get my breasts back. I will not get my, the stuff back. Nothing can be done.
All right. One of the things that is particularly powerful in reflecting on the seriousness of this issue is on both reproduction and sexuality of children, because when children experience dysphoria and they're exposed to social media and other outlets that give them a pathway, you can go to a gender clinic and you can demand hormones or puberty blockers, and the medical system is set up to take your demand as the proof that it's necessary and that it will work and it will be your final solution. Well, that demand carries with it the cost of your reproductive capacity, either through surgery removing the reproductive organs or through the effects of long-term cross-hormone therapy. And on top of that, with the Dutch protocol, which is implementing puberty blockers and cross-sex hormones for adolescents who have just started to show signs of puberty, when they undergo those hormonal treatments, we are now discovering that those patients never experience orgasm, because it's part of your normal pubertal development that circuitry starts to take shape and take hold and become activated. When you block that process, it no longer is a part of the human experience for those people. And that realization, the fact that it's only now, I think it was in the last WPATH conference in 2022, where that observation was finally made, that it kind of shows that this is unexplored territory, and we are experimenting with these people. We're asking children who are not sexual beings to make decisions about their future sexuality that there's no way that they could have any context for understanding. And so that's really it's really a tough situation to be in as a parent, where you're confronted with a kid who really, really wants this thing and feels like it's the only option for them. When you're a clinician and you have parent and children who say, this is what we want, we've read online, we know this is what will work. And then when you have a broader practice of medicine that's saying, let's do this, everybody tends to displace responsibility for that to a level above them. The Nuremberg defense is, I was only following orders. Well, the defense of these endocrinologists is, we are following the guidelines of the American Endocrine Society, or for pediatrics, we're following the guidelines of the American Pediatric Society. And you go to those societies and they say, well, we're following the guidelines of WPATH, and an international body that looks at transgender care. We're simply implementing those guidelines. And you go to WPATH and then they say, well, we're shaping guidelines based on these studies. And so that's where that chain of responsibility for how is this justified gets followed. And that's where it becomes very important to understand the nature of the Dutch protocol, the Dutch study, and all the other things that have come afterwards. Because there's good research and there's bad research, and there are conclusions that can be misapplied. And that's the big concern. Okay, so let's go on to the next issue, because I clipped out some various things that I felt were important to reflect on in that study, in that documentary. Let's see what another of these issues are. Okay, so I think one of the most important things to take away from the documentary is the fact that what we're seeing now is a completely different picture of a patient than what has traditionally been treated with these protocols. Historically, over the 1970s, 1980s, 1990s, and 2000s, early 2000s, when you met patients with gender dysphoria that identified as trans or went through surgery, it was generally older men. And so they were already adults. They had been living their lives, and the protocols were implemented, and any studying that was done was looking at how those men lived their lives after transition. And there were positive results that justified continuing that type of therapy. And then it became more of a challenge when younger patients started showing up, because we started to see children who are identifying this way, and particularly with the discovery first of the ability to isolate the hormones testosterone and estradiol or estrogen, because it gave us, since we understood that those were the primary functional hormones that were involved in sexual differentiation, then it gave endocrinologists kind of some new tools to play with. And then when we had people who had these experiences of feeling different about gender, well, then the endocrinologists would say, well, we've got some tools, let's try them out. And the incentive to create a new medical therapy and to apply it to a patient set can be very powerful for a clinician who wants to make a mark for themselves and can justify that with helping patients. It's something that you have to keep in check and make sure that you're always staying true to the medical ethical principles of first, do no harm, while you're engaging in what initially has to be a form of experimentation. And it should be done with proper oversight by an institutional review board. And that process, if it becomes politicized, it can lead the medical profession down some dangerous pathways. And it's happened before on different other issues, and people critical of this say that it's happening now on this particular question. After the advent of those hormones, then the next thing that you've got is puberty suppressants, where when researchers talk to some of these older individuals who had transitioned, they'll express some of their discomfort or dissatisfaction with having gone through puberty and developed those secondary sexual characteristics that were part of their natal gender. And once they discover the mechanisms and the hormones that would allow them to pause and stop puberty so that someone didn't have to go through it, they assumed then that those older patients would have benefited from never having gone through puberty. And that became then a new concept for a new type of therapy for children who were experiencing gender dysphoria. And so it gave them a new avenue to try out. And that's why we have those early studies on that. But as they started studying those patient groups, again, the exclusion criteria, which is these are the patients we're not going to apply these puberty blockers and cross-sex hormones on, those exclusion criteria would be seen as gatekeeping to the modern Tumblr audience, and it would be criticized as hateful and transphobic because you're telling no to certain patients. But there's an important reason behind those no, and those no is that if this is something that is relatively new, then it's a higher chance that you're being exposed to some social contagion, and that's why you've come to interpret the experiences that you have as being related to gender dysphoria. It's not to say that it has everyone, but it increases the chances. This is something that after your exposure to social media, then you came up and started having distress over your gender. On top of that, if you have some of those comorbidities like autism, like depression, anxiety, you would not have been able to get that therapy. Nowadays, we call that gatekeeping and not gender affirmation. And then if a psychiatrist or psychologist would say, well, let's talk about it. Why do you really feel this way? Maybe there's another reason that you feel this way. Let's explore. That type of exploratory psychotherapy is being called conversion therapy. And so now there are clinicians who are afraid to engage in exploratory psychotherapy because some of the laws have labeled that conversion therapy, and they feel that their licenses would be at risk. So we've actually got institutional and systemic reasons that would punish a clinician for doing something that previously was considered the standard of care. Okay, so let's see what we can find here. ROGD and the new patient cohort. That's the one we want. So we'll share screen, and we'll look at this. Psychiatric diagnosis. Its treatment is Gender dysphoria is a psychiatric diagnosis. Its treatment is internationally accepted. But something's changed in recent years. A new, growing patient group is seeking out gender clinics in Sweden. Young girls who want to be boys. Doctors and transgender people attest to how the treatment eases suffering. But what if that doesn't apply to everyone? What if some people actually need a different kind of help? There are parents who are worried about that very thing. Several don't want to speak openly because their kids are minors. For us, it came out of the blue. We had never, ever felt that our child was anything other than a girl, not in any way. For us, it came as a huge surprise. Our daughter has had mental health problems for many years. She had difficulty in school and with friends and maybe in the family. She had a lot of difficulties in life. Now it seemed she suddenly found an explanation for why everything was so hard for her, and that was a different gender identity. So she came and told me she was trans and that she'd chosen a boy's name. There was so much aggression connected to this feeling. I just had difficulty believing that was really it. And there had never been any indication of this before. She wanted me to help her deal with the doctors. At first, I wasn't to say anything to her father and the family. She was 17 and a half, and they referred her directly to an adult facility. They all say it came up suddenly and unexpectedly in their teens' lives, and the phenomenon has an international name: Rapid Onset Gender Dysphoria, ROGD. In the past, few Swedes were ever diagnosed with gender dysphoria. Then suddenly something happened. The number increases year by year. In 2017, more than 3,500 people were treated for gender dysphoria, according to the National Board of Health and Welfare. And a striking number are young people. More girls than boys come to gender identity services. There might be people in this group we haven't seen before, and who we aren't sure will benefit from this treatment. We don't know how.
Okay, I want to talk a little bit about that graph that they just showed up. Let's see here. Okay, so you can see here where the blue line represents boys that are seeking treatment and the red line is girls. And there's an explosion of natal girls, biological females, who are seeking treatment for gender dysphoria. And it's important to keep in mind that the studies that were done that justified the treatment were here in the early 2000s. The Dutch protocol was published in 2014. And it's being used to justify all of this over here. And so when they say that there's a different patient population here that's being having these therapies applied to it, that's because they're not, if these patients are seeking treatment, they may not be the same profile of the patients that were initially proposed there. So I'm getting a notice that the stream got cut. We'll see how it goes. So let's keep going.
There might be people in this group we haven't seen before, and who we aren't sure will benefit from this treatment. We don't know how they'll be affected in the long run. There's no research. But we do it, and we hope and pray that it will benefit them and that they will be happy. Usually, healthcare is based on science and proven experience. In her opinion piece, she describes it as an experimental treatment. The experimental aspect of this is this curve here, which you also have in Sweden, is that there are people here that we aren't sure will benefit from the treatment in the long run. In Norway, Oslo's University Hospital's ward for transgender children has seen the same increase in teenage girls.
Okay. So we'll pause it here to let the stream recover again, because it looks like it detected copyright issues and locked it off. But I think that point
of the takeaways from this documentary, one of the most important takeaways is that the patient population that is receiving these hormone and surgical therapies is different from the patient population that was involved in the studies that first established those protocols and for which those protocols were claimed to be successful, helpful, beneficial. And if you take a protocol that had very strict exclusion criteria and you apply it to a patient population that it was not originally designed for, you're going to end up with bad outcomes. And so it should not be surprising that we are going to start seeing more and more patients for whom this did not solve their problem because the solution was not tailored to their particular issues. And so what to do about this? Well, the answer, based on the principle of first do no harm, should be to be very, very careful and deliberate about how you implement these therapies. If you have a specific set of criteria that you've used to study a therapy, then you want to start with that patient population as you apply it to a larger population. And you need to continue to do follow-up to see if those results are actually effective. If you look at many of the studies that are frequently cited to say, look, these therapies are positive, there's a net effect, it helped people, it's very tempting to just listen to the headlines, listen to the justification that somebody might use when they give you a link to the study, but you need to go and look at the study, because in some cases those studies are claiming that there's a beneficial outcome when they've only followed up for 18 months, for a year and a half. And if you listen to detransitioners, in some cases it takes several years, 3 years, 5 years even, before they realize that that solution was not the right match for them. And so you really have to have long-term studies to really see if this is having the effect that we're justifying it by. Okay. I'll just say here, okay. All right, we've got some people back to it. Okay, so hopefully we won't have that problem again. Okay, so if you have any perspectives that you'd like to share, I invite you to call. If you're stateside, you can dial 210-422-2222, and it should ring up, and you can share your perspective on this. If you yourself are a parent and you have a child who is going through this and want to share some of your perspective, what you've learned, we'd love to hear from you. One of the things that I'm trying to set up is I'm trying to make sure that my audience has seen some of these issues as they've manifest in Europe, because I have a parent of a trans child who is going to be joining me for some commentary as we look at the testimony given before one of the subcommittees in the Ohio state government as they explored the question of whether or not they should ban transgender hormonal and surgical care for children. And having that perspective of somebody who was there and can give us their views on it, I think will be important. But it's also important to know this information about what was going on in Europe and why Europe reversed course in order for you to understand some of what the experts testifying talk about. Okay, so let's see here. I think we can explore, they just talked about how in Sweden, the flood of young women who were seeking treatment for gender dysphoria came to those clinics with a bunch of comorbidities, and that this was not just unique to Sweden. Now they're going to talk about, I think, Norway having a similar experience. Let's see. They're concerned about what that means, because they've also seen something else that characterizes this group. So in the past 5 years, since 2012, there's been a huge increase. And again, what we see is that most of them are teenage girls. But then we see this group is those who are born biologically female, and these are born biologically male. And you see that in the teenage group of those born biologically female, over half of them, nearly 60%,
have a complex mental illness. They're carrying significant trauma with PTSD, post-traumatic stress. They're on the autism spectrum. They have severe clinical depression, psychotic symptoms. In Sweden, more than half of these teens also have other psychiatric diagnoses, such as self-harming, autism, and anorexia. And several describe other traumas, such as sexual abuse. Are the same evaluation model and treatment from the past really right for this new group?
Okay, and that is the big question at the center of it is, should we be applying the same treatment model to this complex group of patients that have all of these comorbid psychiatric diagnoses, because the treatment model was designed to specifically exclude patients who have those diagnoses. And that's the thing that gets lost in these conversations when the clinicians come in and they face questions in these various hearings. I don't ever really hear them dig down to this one question of, is this the same patient population that those studies were designed to treat? Because if they're not, how can you justify treating them? Because that's a conversation that really needs to be had. Okay, so let's see here. If you want to join in the conversation, I invite you to go ahead and call 210-422-2222. I know it can be a difficult thing to talk about. Let's see, what other things? Okay. One of the, you saw in that clip, the people who were sitting in the dark that didn't want to be seen. And these were parents of kids who had gender dysphoria and went to gender clinics. And what you'll learn once you start to dig in this is that you risk being vilified if you raise any criticisms. And as a parent, you risk being alienated from your child, because in the online social media discourse about this issue, one of the messages that gets included in all of the other messaging is that anyone, especially and including your parents, who tries to get you to think differently about this or who does not agree with all of the things that you want is a hateful bigot. And you need to cut them out of your life, or you should separate yourself from them, or you should see them as being your enemy or opposed to you. And so many parents are afraid to actually speak their true feelings to their kids. And that question of rapid onset gender dysphoria, which is, they call it rapid onset because it occurs usually in adolescence, in the teenage years, to kids who the parents will say there was never any issue. My daughter was always happy and proud of being a girl. And then she very frequently and almost always, she got internet access. She had exposure to Tumblr or fandom groups or TikTok. And then things changed. And then she came out as non-binary or as trans, or she said that she doesn't feel like she's a girl and she never was a girl. When you speak to some detransitioners who went through that process, they'll say that not only were they told that they should see their parents or teachers or family members as bad if they didn't agree, but they were also told that they needed to make sure that they related their experience of gender dysphoria as being longstanding, as saying that, oh no, I never ever felt like a girl. I always felt like a boy, but I just had to hide it. And that's why you see this as rapid onset, because I was living in fear my whole life. And so I could never feel open to it. And those scripts, which are the things that you need to say to make sure that you get treatment from the various clinics, detransitioners say kind of get passed around, and so people will be exposed to them. But that's all adds up and just to the information that will be a part of the understanding that your kid has as they navigate the social media world, and changes their perspective on how they see themselves, how they see the world, how they see their family. And so once you start to see that, you can understand a little bit why those parents may want to hide themselves. And it may not be so much that they're afraid that the wider community is going to vilify them. It may be that they don't want their kids to know that they have concerns that they're talking to journalists about.
because they want to try to preserve what relationship they can with their kids. And that's something that a lot of parents can really relate to. Okay. So there's this phenomenon where parents will be faced with a child who says that they're having distress over their gender and they won't know what to do. But we have medical professionals who deal with this stuff. So we'll go and talk to our family practice doctor, our pediatrician, or we'll talk to a therapist. And they'll speak to the therapist, and the therapist may not feel comfortable treating these types of patients because it's something that is unfamiliar. Very few training programs deal with this of the people who are practicing now. And so they'll say, well, I can't deal with this. I'm going to refer you to a gender clinic. And a gender clinic will generally be headed by somebody who was trained in the ways of dealing with this gender dysphoria, which automatically assumes the protocol. And they're generally taught that the Dutch protocol is how we treat these patients, and we do it in an affirmation model because that is the way that practice is shaped. And again, if you want to ask questions, why do you do that? They'll refer to standards by professional societies. If you ask those professional societies, they'll refer to WPATH, and then they'll refer back to these studies. You have to follow that chain of accountability and medical evidence to see how studies that have very questionable conclusions and study design have been used to justify these protocols that are then applied to very broad patients worldwide, if you want to understand this. But what parents want to have happen usually in this situation is they expect a medical professional to explore this issue with their kid to try to understand it better. And that exploration does not automatically mean that the answer is no. They assumed that there was a process where they excluded other causes before they proceeded with hormones that have irreversible changes. And so that is the crux of the next issue. Okay, so let's go to the next video.
The doctor we met asked one question: "Are you sure?" And our daughter, 15 at the time, said, "Yes." So the doctor said, "Then we'll send a referral to the gender identity clinic. Congratulations, you're so brave. No follow-up, no further questions. About how did you arrive at this, and what does it mean to you? How do you feel about this?" It was just congratulations. The answer we got was, we don't say no to anyone. We affirm everyone who comes to us. And it's very important to affirm this, not to argue. It's a question of identity, not a diagnosis, a question of identity. Here at ANOVA, we have a standardized evaluation format for most people. That makes it more efficient, so we can work faster, so to speak. So people don't have to wait. How often do you say no? It's been many years since we didn't agree with the patient. So when someone comes to talk to us, we don't say no. We conduct a joint evaluation. The patient has to live in their body, not us, whatever it looks like. We don't feel that the healthcare system is providing anything but an offer of hormone treatment and planning for surgery to surgically alter our child and help our child to change her sex, which validates that there's something wrong with her. It confirms her feeling that her body ought to be different, and that she's strong and brave to pursue this. I'm sure the system wants to do the right thing. I just don't understand that they don't seem to consider that this is a new patient group and they need to proceed with caution. We ask how many people regret the decision, and they say none of them. We would have expected that adults, doctors, psychologists,
therapists could tell a 15-year-old that we think your problem is something else, that they'd realize that's the case, that they'd be able to say, we don't think you'll feel better from hormones or surgery. We think you need this instead. Now it seems there is no adult who wants to tell our child that.
All right. So again, you have these parents who are concerned that turn to the medical professionals with the assumption that the professionals are going to ask questions to dig deeper to try to understand. And what they're faced is that the professionals don't do that. They've adopted an affirmation only model, which is that the only trigger for further intervention is if whatever the child says. And so they'll turn to the child, they'll say, do you believe that you're a boy or a girl, or what do you believe? And then whatever the child says, they'll say, okay, we're going to take steps now based on that decision. Again, it's a mix of things where clinicians have the understanding that this is going to be in the best interest of the patient, because they believe that the conclusions from the Dutch study are true, and that if they apply this whole cascade of events, puberty blockers, social transition, cross-hormone therapy, and sexual reassignment therapy, that there will be a better outcome at the end of it. And so they trust the science, they trust those studies, and they cement that trust because there's these professional organizations who have endorsed those studies. But if you go back and look at those studies, they're being applied to a very different patient population. And the parents are starting to wake up to this, because the parents are talking to themselves. They're talking to other clinicians who have raised questions about this, who have concerns about how it's being done, and are informed from the medical perspective about the problems with the studies. And they're saying, hey, this is a different patient population than the Dutch protocol that informed WPATH, that informed the professional societies upon which you base your protocol. And since it's a different patient population, you need to slow down. You need to make sure that that's the right process, because you cannot be sure that you're not doing harm to my child. But when you have parents who raise these questions or concerns, who aren't immediately willing to fall into the affirmation-only model, in some cases, you'll hear that the parents are informed by the doctor that they are being hateful and bigoted towards their child, and that if they don't immediately adopt an affirmation-only perspective with their child, that they are going to be causing the suicide of their child. And it's that type of coercive argument that sidesteps the question of the evidence basis for this therapy. It absolves the clinician of the responsibility to first do no harm, and it's setting up a system that is causing more and more people that will eventually detransition and have some very bad outcomes. So, okay, so it looks like we had another trigger. I don't think anyone is reporting this stream. I think YouTube has algorithms to try to detect copyrighted material, and the Swedish documentary producers have flagged this as copyrighted. They don't block it outright. It's still allowed to be shown in some countries. It's just that for a live stream, it triggers a block, but it should resolve itself. So we're taking a little bit of time. In the meantime, if you would like to share any of your perspective, you can call 210-422-2222. We'd love to hear from you. So let's go back to see other things. Okay, so the question of puberty blockers becomes important
when a young person starts their
particularly when we get to the later episodes of this documentary series, where they explore very specifically the question of young children and puberty blockers and the unknown effects of that. This first episode covers a little bit of it, but just stay tuned because we'll go into that a little bit more. But there is something to understand, which is that there are effects that these puberty blockers have, which are known as they've been used for other indications. And
There's been some controversy because the initial publications by some of the professional societies have said that the effects of puberty blockers are completely reversible, and they are simply a pause button that allows patients to slow down, to consider their options, and then either proceed with puberty. If they decide that they've desisted, they'll proceed with their normal puberty for their birth gender. Or if they decide that they do want to proceed with further cross-sex therapies, that they'll undergo those cross-sex hormones and sexual reassignment surgeries. But what we've started to realize is that it is not true that puberty blockers have no irreversible side effects. And that is particularly in regards to bone density. And we're starting to understand it also involves brain development and IQ and sexual function, particularly with with messing up the mechanisms of being able to experience orgasm and sexual arousal. So let's take a look at this next segment that deals with the known effects of puberty blockers. When a young person starts their journey towards transitioning, they are given puberty blockers, hormones that stop puberty. These powerful drugs are being prescribed to 15 to 19-year-olds. Doctors say the body returns to normal development after the treatment. But no one knows what happens in the long term. One research team is seeing a patient's IQ dropping. Other research finds risks of osteoporosis and that puberty blockers can affect the brain and heart. The Medical Products Agency approves and tests medicines, but it is doctors who decide who get these drugs. The same drugs and same doses used in chemical castration of adults. Physiologically, some of these things are to be expected. We know that castration has an effect on the heart, and we know there's a risk to the bones with castration. And there's also a mental effect. That's something we see with castration of both men and women with the treatments that exist. And these are the same drugs? Yes, the same mode of action. So we'd expect to see this in girls. I would expect that to happen. But these are healthy teenage bodies that are still growing, that are perfectly healthy physically, and they're being prescribed these strong drugs. What kind of benefit do they get to make it worth it? Once again, I said, I think it's about being able to show that the individual is happier despite the risk. In Sweden, the rule is that puberty blockers are given for up to 3 years. The next step is testosterone. Hormone treatment is lifelong, as are the physical changes they cause. There is also a risk of side effects, cardiovascular disease, and cancer. Testosterone was designed for men, but in several Swedish countries, it is prescribed for more girls than boys, aged 15 to 19. We've never seen such numbers before. What are your thoughts on that? If you make a major policy change, you have to have some kind of evidence that it's based on. And in this case, the healthcare system has made that judgment. So the healthcare system has to answer you about the basis of that decision and the change in treatment methods. That last segment is particularly revealing. This is a guy who's involved in approving or implementing the safety of medications, but he's displacing any responsibility for why these medications that have these known side effects are being recommended for patients who have otherwise healthy bodies but are experiencing this dysphoria. And he's saying you have to talk to the people who make the decisions that implement these protocols about it. One of the things that's particularly, I think, a concept that I want to make sure that at the end of all these different videos that I'm able to put out there is something called cascade iatrogenesis. And it deals with something that's an iatrogenic injury, which means that it's harm that's done to a patient as a result of therapy. As doctors, we want to be able to maximize the benefit and minimize the cost and the harm done to a patient. And we have to first make sure that we're not doing harm in order to implement these benefits. And when that system goes awry, then they'll say that we've committed an iatrogenic injury. That's the first concept. The second concept is something called a therapy cascade. And a therapy cascade is when you do one intervention and it leads to subsequent interventions that would probably not otherwise have taken place if you didn't do that first intervention. And in some cases, those subsequent interventions may end up having worse side effects than what you initially treated the patient for. And so realizing when you've initiated a therapy cascade that can lead to iatrogenic injury can be really difficult, because you may be assuming that that first intervention is having a positive result if you're not stepping back and looking at the broader picture of what subsequent interventions end up doing. There's a few classic examples of therapy cascades that ended up in iatrogenic injury. I think one of them that I read about was something called the PSA test, prostate-specific androgen. It was a blood test that could detect patients who had a high likelihood of having prostate cancer. So we had this tool, this test, that we could then apply to everyone. Prostate cancer affected a lot of men, and so we started, as part of routine screening, giving men this PSA test. And it came positive in a lot of patients that would then undergo subsequent imaging procedures, biopsies, surgeries, with the idea that we were going to save lives and improve quality of life by detecting prostate cancer early. Well, it turned out that prostate cancer, in many cases, is very slow going, and a lot of people die not from prostate cancer, but with prostate cancer. But by applying the PSA test very, very broadly as part of a screening paradigm that then had a bunch of subsequent tests that would happen, the medical profession, if they looked at all the data, may actually be producing more harm to a broader variety of patients simply by doing that test, because it leads to a cascade of further intervention. And so it's caused the medical profession to reevaluate how they implement that PSA. That doesn't mean that you stop giving the PSA, but it may mean that you limit the people that you apply that test to in order to make sure that you receive optimal benefits and minimal cost, risk, or harm. And so that same paradigm of cascade iatrogenesis needs to be kept in mind when we look at some of what we just covered. So if you step back in time and look at how the watchful waiting paradigm existed, that is, if you have a young child who reports an experience of gender dysphoria, then you don't immediately socially transition, you don't administer hormones in the form of puberty blockers or cross-sex hormone. What you do is watchful waiting. You do exploratory psychotherapy. They are given support in terms of their family, but the concept is to wait and see, to experience more of life, to explore any potential psychological trauma, underlying psychological issues, and to deal with those, and wait and see if, once those things are resolved, once the patient grows a little bit and matures a little bit, if their perspective on their gender dysphoria changes. And historically, when they studied this process, a number of studies published how many of those patients that started out in childhood experiencing gender dysphoria, that by the time they were at the end of puberty or were young adults, how many stayed experiencing gender dysphoria and how many desisted and no longer were reporting gender dysphoria. And if you look at those studies, anywhere from 50 to 90%, even 98% were reported to have desisted. And what this gives us is a snapshot of the natural course of this particular process. And that is that we would expect that children, young children experiencing gender dysphoria would, in most cases, grow out of it. Now, if you start bringing this up with people who've done some research into this process, a frequent objection that they'll give is, well, the criteria that those early studies used for gender dysphoria is different from the criteria that we're using now. So you can't use the same data to make that argument. And this is where Ken Zucker, one of the original researchers that was involved in WPATH and designing this, these protocols, address that question, he went back and looked at some of those studies and applied the current standards for gender dysphoria to their data to see if they had similar outcome. And the result was, yes, a majority of the patients in childhood presenting with gender dysphoria will eventually desist. So if we were to look at 100 children that were experiencing gender dysphoria and we follow them as they grow up, then we would expect something like perhaps 60 to 70 of them to desist. And so at the end of childhood, we would be left with 30 patients that still were experiencing gender dysphoria as young adults. And if you follow that out even further, the argument could be made that there may be even a drop off of more than that, but by the time they're adults, they can start to make choices for themselves, and they are at the age where we understand as a society that they can consent to doing surgical alterations and hormonal therapy. So the problem that you'll see with a lot of these studies is that they don't do randomized controlled study design. And the reason is they say that it's difficult to justify the ethics of only treating half of the patients or one arm of the patients with surgery, hormones, and the other not doing that. There's no way to be blinded, and so we don't have a control. And so when you can't have a control, you can at least understand what the natural course of therapy would be. And that gives you something then to compare when you initiate an intervention. So when we look at what happens when you start socially transitioning and then administering those puberty blockers, the justification that's given for us is that it pauses their normal puberty and allows them to figure out who they are. And then they can branch off after a course of time. They can either stop the puberty blockers and continue with their normal puberty, or they can start cross-sex hormones and continue with what they are calling a cross-sex puberty. They would experience the puberty of the other gender. Now, that's actually an artificial construct because every cell of their body is specifically of their birth gender, and simply giving the opposite gender hormone while blocking the natal sex hormone is not the same thing as a natural puberty of the opposite gender, but that is the marketing that it's coming under. Well, the studies that have started to look at that have noticed that if you start 100 patients on that intervention, what you would expect is that we'd see a pause of puberty, and then we'd see about the same number that would have resolved with watchful waiting, decide, you know what, I've paused puberty, I'm good, I'm going to continue with my normal biological development, let's get off the puberty blockers and I'll grow up and I've resolved my gender dysphoria. You would expect the same number to do that, but that's not what's happening. What's happening is when they intervene with puberty blockers, something like 99%, 98% stay in that dysphoric state and continue on with further hormone and surgical therapy. And what that means is that the intervention is actually disrupting the natural course of the disease that we would expect in a population, the natural course of the discomfort that they have, which is that it should resolve in a very significant percentage of those patients. So when you step back and compare those two pictures, what you realize is that by giving the puberty blocker, you're actually intervening in a way that makes the dysphoria persist in patient populations that it should not persist in, and that is causing then subsequent therapies in the form of cross-sex hormones and surgery. And so you're initiating a cascade of subsequent therapy. And so that cascade carries with it all of the harmful effects of the subsequent therapy, because when you start looking at the side effects of the puberty blockers, the side effects of the cross-sex hormones, the sterility, the psychological effects that happen just with living the, all the challenges that somebody with living their life in the trans identity, that it carries a significant psychological toll. Dealing with the side effect of the surgeries. When you look at the surgeries that are undertaken for reconstructing the sexual reassignment surgeries, they are very invasive surgeries. They carry a heavy risk of complications. And all of those things down the line become part of the harm that the medical system is giving to these patients who would have otherwise desisted if they were not initially started on that cascade of therapy, if exploratory psychotherapy was the only thing that was initially done. Now, that's a long, convoluted way to try to explain this concept, but I really think that I wish there were a more marketable name for cascade iatrogenesis, but cascade iatrogenesis is an important concept to understand when you look at this issue. And that's all the stuff behind it. So, okay, so if you are interested in sharing your perspective on this issue, you can call 210-422-2222. And let's see here. There's some other that I want to go ahead and take a look at. So one of the questions is, if we are actually doing this wrong, if we are actually applying this therapy to a broader set of patients than we should be, then why aren't we hearing about it? Why is the detransition phenomenon not as wide as it is? And there are some social reasons that that's the case, and that is that there appears to be a taboo of people talking about it. And so that's one of the things that the documentary covers. So let's take a look at that aspect of it. How many people regret transitioning? A Swedish study shows that from the 1970s until 2010, only 15 people, 2.2%, regretted it. But how many of this new group will regret it is an unknown. We must be affirming, and of course, you can have hormones and surgery. And it will only take 6 months because we can see you're unhappy. It gives me chills when I realize how fast this can all go, and how carelessly they're treating this group of patients who are quite fragile. I want to tell my child and the healthcare system one thing: this must not be hurried. We must have the option of waiting. It should be the main alternative. Waiting until you've reached maturity. Wait a couple of years. Live as a man, as the person you want to be. Express whatever gender you want, but don't do something you can't change. Don't do anything irreversible to your body. What the healthcare system told me was that basically no one regrets it. Meaning someone like me, born biologically female, who goes through the whole transition and then goes back. I had never, ever heard of such a thing. Regretting or detransition is a sensitive subject in the trans world. We've been in touch with Micah for more than 6 months. She has been plagued with doubt about telling her story. I'm afraid to show my face, because detransitioning is such a terribly sensitive topic, and because this is a reality that we don't want to exist. We don't want it to be real. I don't want to show my face because I'm afraid of the consequences of how people will react when I tell my version, which has never been told in Sweden in this way before, because many in the trans and queer community would see it as a threat that it even exists, that there are people with different stories. We want so much for things to be simple, that the treatment is easy and that everyone is happy afterwards. And we're very good at giving that impression to gain more acceptance and understanding and so on. And I do see the point of that, but we have to show all the stories. Not to hurt anyone, absolutely not, but to give the best possible treatment and to give people the correct diagnosis. British psychotherapist James Caspian has worked with transgender people at his clinic for many years, but his proposal to do his master's degree on regretters was turned down. He's now taking the matter to court. He says it's taboo to even talk about the existence of regretters.
I think that it's not just considered to be a politically incorrect research topic, it's considered to be a politically incorrect topic to discuss. But it isn't that simple, because we have to listen to what people are saying. Until I got into this, I didn't really have an opinion about people who regretted. We thought they were very small in number. No one ever really talked about them. But I started to hear that there were more and more of them. And what they were saying to me was that many of them felt damaged and traumatized. They felt that when they said that they were reversing their transitions, they became very unpopular. Some of them were vilified. There have been cases of people being very abused on the internet who've reversed transition. And so then they don't want to speak out. So I think they wanted to speak through my research.
There's this huge taboo, and I think it's viewed as like a really scary threat against the classic trans narrative. So I think that covered this really important thing to understand, which is kind of why, when you ask, how frequent do transitioners happen, you're either met with, oh, it's very, very, very rare. It almost never happens. I can't even think of one. There was a hearing that was broadcast recently with some researchers that were confronting one of the government agencies here in the States, and they asked this question: do people ever detransition or regret it? And the response was, I've never heard of that. I've never come across that. And when you start to see how frequently the stories of detransition are, whether you look on YouTube or you see documentaries like this, it is a reality. And what these stories should be informing the medical community of is that, hey, something has gone wrong in the way that these therapies are being applied. And you need to at least understand it so that you can see if there is some tweak that you make to your selection, your inclusion criteria, your exclusion criteria for these protocols, so that we can try to identify these patients that would subsequently detransition and make sure we don't apply an incorrect therapy to that patient group. But even raising those questions gets you branded as a hateful bigot. And there's some powerful reasons for that they try to address here. One of them is the idea that it goes against or is a threat to what is considered a trans narrative. And one of those narratives is that a trans individual is inherently trans from birth to adulthood. And so that's why the presence or the existence of trans children becomes very important. And that's why you need to affirm only, because if you do anything other than affirm only, then you're doing something that is the equivalent of deconversion therapy for gay people. And that's because the gay paradigm is along that lines of you are inherently gay from birth to adulthood. And it's not something that has anything to do with your lived experiences or information or ideas that you're exposed to. And if you listen to the lived experience of detransitioners, you can see it's not as clear cut as that. And in some cases, there are complex psychological reasons that somebody is dissociated from their body gender and does not feel comfortable coming to terms with the reality of their body's gender, and it causes them distress and anxiety that gets described as and treated as gender dysphoria. And if you limit your options for dealing with that experience to only affirmation, only hormones, only surgery, then you're missing the patient population who might have that dysphoria resolved through exploratory psychotherapy. And since you're giving the wrong therapy to that cohort of patients, they're going to have harmful effects down the road. And those harmful effects are hard to recover from because those therapies involve irreversible changes to their body. The reason that a lot of people think that we have grossly underestimated the percentage of detransitioners is because the detransitioners don't want to talk about it. They feel that they have been severely harmed by the medical community. In some cases, they see the clinics and the doctors as having hurt them deeply, and they don't want to be involved in anything to do, whether it's a study protocol or follow-up, and they want to simply get on with their life and try to salvage what they can about it. Because you have this dichotomy of, once you identify as trans and you go down this pathway, you're met with celebration. As we heard some of the parents say, even the doctors were congratulating the children on saying, you're brave, you're courageous, it's fantastic that you're doing this. But if they make the opposite choice and say that it wasn't for them, they're not met with that same degree of congratulation about being brave. They're met with vilification, because that story that someone could identify as trans, could be trans, and then later regret it, is a threat to other people who maintain that they are trans because they believe that it would promote the idea that what they are is the result of choice or indoctrination and not who they authentically are. And it doesn't have to be a black and white issue like that. You can have people who, for whatever reason, were led down a path of believing that they were something that they were not, but there can be other people for whom that is a real reality for their life. And the medical profession should be able to distinguish between these things. And part of the way that you would do that is to say, okay, well, let's explore these different patient groups that we're starting to see now that are very different from 20 years ago when we identified children with gender dysphoria. And that's where the work of Lisa Lippman becomes important. She was a physician who started to look at this question and question parents about, what was happening with their kids, and published a study and coined the term rapid onset gender dysphoria because there was a pattern that seemed to emerge of young women who had been exposed to peer groups and social media that started to experience gender dysphoria and identify as trans. And it was a new type of phenomenon that wasn't reported previously in the descriptions of patients that experienced gender dysphoria for whom those therapies had been applied. And when she published this study, the journal that published it, her own work, was heavily criticized and vilified because it, again, was a threat to a prevailing trans narrative. And very politically active trans rights activists have the ability to make things very embarrassing or hurtful by labeling institutions or journals as transphobic or hateful because they interpret their work as those things. So when the medical community is prevented from being able to freely explore the various facets of the patient populations that they would apply a therapy to, then you're going to end up with bad outcomes because they're not able to stay true to those principles of first do no harm and evidence-based practice of medicine, which in order for you to apply evidence-based medicine, you have to make sure you're applying it to the right patient population. And understanding where therapies go wrong as manifest in this detransition population is how you would understand and better select your patient for use of that therapy. So it's a really important segment of the documentary. All right, so I think my stream has been blocked. So we'll just say that you can try Facebook. It may not be blocked there. And we'll see if that happens. Okay, so let's see. There is another group. I'm not even going to bother asking people to call in because I think that the disruption of the stream has had that. So another important part of this documentary was the question of if you have these concerns as a parent or just as somebody interested in this issue, does it mean that the only answer is that we need to immediately stop any and all therapy for anyone? And that is one extreme, but it's not necessarily the extreme that the concerned clinicians who are trying to adhere to medical ethics are taking on this. They're not saying that we shouldn't do anything, but they're saying that we need to slow down and we need to make sure that we're sticking to those first principles. So it's not do nothing, it's slow down and be very thoughtful and deliberate and true to some basic ethical and scientific principles before we do that. Okay, so let's take a look at this next segment. I'm going to share the screen for slow down versus stop. And let's see where we are.
Marcus Evans, an experienced psychoanalyst, thinks it's wrong to just affirm teens seeking help for gender dysphoria.
My worry is we're letting kids down. We're rushing things through under pressure in order to make everybody feel, right, we've solved the problem. When in effect, we haven't solved the problem. We've just fitted in with a quick fix. And it's not that I'm saying people should never transition. That's not the point. It's just slow things down and think things through with them over time and in depth. We're saying there's no long-term research studies. We don't really know about the effects, the long-term effects of the hormone blockers. what's going on? We just don't know, but we're acting as if we do. I wouldn't get myself into an argument. I'd say, okay, that's what you believe. And I understand that's very important, that I understand how you want to be seen. But my job is to try and understand who you are, you see, and what drives this sort of perception. You know, so I don't want to get into an argument. I'm trying to empathize with the individual and the way they want to be seen. But I've got my own mind, and my own mind is thinking about them as a person.
All right. So this is where this particular psychoanalyst was part of the Tavistock Clinic in the UK. And when the documentary makers approached Tavistock to try to get information about their patient populations, bad outcomes, detransitioners, how they were implementing their protocols, they couldn't be as open as possible. He stepped down from the board because he had grave concerns about how they were approaching their patient population, how they were implementing the protocols, and he was then willing to talk to the documentary makers because he thought that they were inappropriately applying these protocols. And the mark of, you know, a clinician who's taking a much more nuanced approach to this is what he just said. It's that it's a psychoanalyst that when confronted with a child with gender dysphoria, he's not simply going to say, congratulations, here's your prescription for therapy blockers. They're going to explore other options. They're going to take time to do it and undergo, you know, a more extensive process than something that is very brief or cursory, and that is how they're going to give a chance for some people to make the decision that it's not for them, and then those people that do persist will go on to that. There's another testimony by a Dr. Stephen Levine. If you look at I think it's the Florida hearings, he does a phenomenal job of laying out the case for this. And he's got an excellent interview with in Gender, the Wider Lens podcast, where they explore more of this concept of the clinicians being able to see the patients with gender dysphoria as very complex people that have all sorts of things going on in their lives that make up the tapestry of their experiences. And they have an understanding of adolescent development and the various phases of their lives that people will subsequently undergo, and bring that experience to bear in talking with someone and trying to understand the complexities of their experience of gender dysphoria to try to best select patients that would go on to surgical or hormonal intervention, and those that would benefit primarily from exploratory psychotherapy. All right, so let's see here. I think if we stop that screen, and then there's just a few other important concepts. One of the things that gets explored in the documentary is the question of who bears the ultimate responsibility for the bad outcomes. And they approach one of the pediatric endocrinologists or pediatric psychologists on their kid team, and they approach a few other people with it. And in every case, there's this odd phenomenon where the clinicians are diminishing their responsibility for the ethical practice and evidence-based practice of medicine by saying, well, the parents agreed to it, or the kid was in such distress, we had to do something, and so the kid bears some responsibility for it. When, you know, this new population of kids are ones that are coming in with serious psychological comorbidities. They're anxious, they're depressed, they're autistic. There's all sorts of very complex things going on with them that the parents are turning to the clinicians, trusting that the clinicians are going to implement the same type of evidence-based ethical practice of medicine that they trust them for diabetes, for any other number of medical ailments. And so for the clinicians then to pass some of that responsibility on to the parents and the kid seems like a mismatch of priorities, but we'll see how it plays out. Okay, so this is on displaced responsibility. And we'll go to present share screen.
The risk of young people getting an incorrect diagnosis and an irrevocable treatment has barely been discussed in Sweden. But a few years ago, the Lundström Clinic noticed that patients were coming back. Now they offer trauma care for detransitioners. The Lundström Clinic saw patients returning, and that affected the staff who make the diagnosis and treatment decisions. There's an awful lot we don't know. That's what creates this, what we call an ethical stress, that we don't have satisfactory evidence for what we're doing.
All right, this admission in this documentary is actually really powerful, because what this one clinic is saying is that they're acknowledging the reality of detransitioners, and then they're reflecting on, hold on a second, if we're having this many patients come back saying that the interventions that are irreversible that we've done to them are actually hurting them in the long run because they don't address their core issue, because they have they've detransitioned and now have regretted it, then if we took them down that line of therapy based on flimsy evidence or based on a misapplication of a particular protocol, such as the Dutch protocol, then we've done them harm, and it is our responsibility. And that cloud of very hard realizations, they are giving the name ethical stress. But that ethical stress should be a big wake-up call and impetus for them to immediately put the brakes on and say, hold on a second, we need to regroup, we need to step back and say, are we doing this the right way? Is there a better way for us to select the patients that we take down this pathway? Because these are serious complications that we are giving to these patients who, if we had not done this, would by all expectations, statistically would have more likely have desisted and gone on to a life without all of the complications of the interventions that we've given them. And so that concept of ethical stress, the fact that they've given it a name that sounds a little bit banal, is one thing, but it's a serious admission on their part.
The staff experience ethical stress, yet the treatments continue, hormones and surgical procedures. On girls, the breasts are removed, and the number of operations is increasing. We ask for the ages of the surgical patients. The hospitals say the youngest are 16, but only with parental consent. All hospitals release data on the number of operations per age group, except for Karolinska. Perhaps it is sensitive, for nowhere else in Sweden are individuals as young as 14 given gender-affirming surgery. If I'm tormented by my breasts to such a degree that I can't show myself in public, and I can't hang out with other young people, if I can't go to school, if I can't feel happy in my body, then it's reasonable if all the parents, us medical professionals, and the young person themselves all see it that way, to help her not have to deal with that bust. Can a 14-year-old really understand the consequences of such a decision? If it is a very young person, then we make a particularly careful assessment. But you're quite right that there is a dual ethical problem. The unethicalness of not helping to ease their suffering, and also there's the unethicalness in that the patient may change their mind 15 years down the line. And whose responsibility is it if that happens? Well, since these decisions are based on consensus between the child, the parents, and the professionals, then it is a shared responsibility. shared responsibility? They're placing part of the responsibility on a child with psychiatric problems. Looking back now, I think it's actually completely sick how this process plays out. Because there's so little support for all this. At the heart of it, the healthcare system is the one responsible. They're supposed to provide a correct diagnosis. They're supposed to be able to say, you're getting this treatment because we know it will make you feel better. The national guidelines for the care of young people with gender dysphoria, written in part by Karolinska's own doctors, recommends top surgery with gender reassignment, even though the scientific evidence is insufficient.
So, that moment where he's describing who shares the responsibility when things go bad, and he says, well, the decision is made on consensus. And then he lists the doctors who should have the clinical expertise and should be applying ethical principles and evidence-based practice. And he lists the parents. The parents have turned to the doctors for their expertise. The parents don't know which therapies are right. They are trusting the doctors. They are trusting the medical system, which should be based on those ethical principles and evidence-based practice. And then they're listing the child who themselves has psychological issues, which would incidentally exclude them from the therapy if they strictly held to the Dutch protocol. And so it's a way to diminish and kind of sidestep the ethical responsibility that the clinicians have, so that they don't have to see that what they're doing should be the result of ethical stress. And he mentions first that there's a dual ethical problem. One of the ethical problems is, well, we have to do something. These kids are in distress. And that's a legitimate observation. But because somebody is in distress, you have to make sure that the intervention that you do is ultimately going to have a good chance of being to their benefit. There has to be evidence that it's going to both be beneficial and that you're not doing a harm that is greater than the benefit. And when you listen to the critics of how this protocol is being applied to the larger, broader population in America in the various state hearings, the critics almost always invoke the principle of first do no harm. And they say that the way that they're applying these protocols to children in America is betraying the principle of first do no harm, because if you wanted to stay true to that principle, if we already know that a high percentage would desist with watchful waiting, and instead we implement a protocol that eliminates that desistance rates and carries everybody through to further intervention in the form of hormones and surgery, then we are doing harm and betraying that principle. And so that particular clinician is one involved in their child gender clinic, and he's got strong incentives to defend what they're doing. And it doesn't look like he's reflected much on ethical stress, but if they are blind to the rates of detransitioners, if they are adopting protocols without critically analyzing them and seeing if they're applying the same population cohort to it because everybody else is doing it, and that's what the standards say, then there may be issues. And that document there that they say that there's little scientific basis, if you go and look at the Endocrine Society's recommendation for treating children with gender dysphoria, in their recommendations, they rank all of their recommendations according to the strength of the scientific evidence. And when you look at how they rank it, they do not rank it high. It's very low. In fact, most of their recommendations have low or very low evidence for it. But they can simply point to other international standards bodies like WPATH and say, well, these people have set the standard and we are going to implement it. But when you look at the language that's used, there's a difference between standard of care and guideline. And they'll say that these are guidelines, they're not standard of care, because there are certain criteria you have to meet in order to call something standard of care. So it may be that it's not going to, we're not going to see the end of this until some lawsuits start happening where they go to these clinics and these doctors and say, upon what basis are you implementing these practice? And then they'll point to some international body or some professional agency, and they'll have to bring people in from those institutions to say, on what basis do you do this? And then we'll start to see perhaps in America the same type of reversals that they are implementing in places like Sweden and Finland and the UK. All right, so let's see if there were any other. Okay, I think that's probably all the clips from the video itself. One thing I wanted to do is take a look at the comments. The documentary's only been up for a day. We have a handful of comments on it, but let's go ahead and take a look and see if there's any comments worth addressing. Okay, so this is the page for the documentary itself. We'll go ahead and just go to theater mode and look at the comments section. Okay, keep shining your light. Thank you for your comment. Thought-provoking material. Looking forward to part 2. Let's see. Ute Hagen says, additionally, the Dutch studies were funded by a Dutch pharmaceutical company, a producer of puberty blockers, pharmas. And that is a true observation. When you look at the journal articles publishing those initial studies that describe the Dutch protocol, it lists that the work was sponsored by the company that actually produces the puberty blocking medications. And I think if you were looking at any other type of therapy, you would say that that represents a potential conflict of interest or a potential source of bias that should be part of how you frame your understanding of the findings. And you would want to look forward to future research that reproduces their work in other institutions, something that implements a protocol in a multi-institutional way that has continued longitudinal follow-up, but those types of studies have not been able to be done. Uda goes on to say there were originally 70 subjects, mysteriously then only 55. One died in the aftermath of surgery. Not great stats are qualified as reliable foundation for mass medicalization. That's very true. If you go down the rabbit hole at looking at the Dutch study, there's a bunch of questions that get raised in terms of how they're reporting and the conclusions that they make. I think one of the most impactful bits of information that you'll get is when they say that patients reported an improvement of gender dysphoria. The way that they were able to do that is they had to have some way of quantifying the degree of gender dysphoria. And there's a scale for gender dysphoria, which takes the form of a list of questions in which the patient ranks their experience of dysphoria for a number of different items. But there's a separate list of questions for boys than there are for girls. And for the patients that went through their protocol, they gave them the list of questions for their birth gender at the beginning of the study. And then at the end of the study, they gave them the list of questions for their transitioned gender. So it was a different set of questions. And one of the concepts in doing evidence-based medicine is if you're going to use an assessment tool to assess the rate of change of something, you kind of have to use the same assessment tool if you wanted to be able to gauge the degree of change of your intervention. These gendered questions included things like for the boys, do you feel discomfort when you stand to urinate? For the girls, do you feel discomfort when you experience a period? And you can imagine that somebody who is biologically male who never experienced a period, excuse me, would have a certain answer to that. I think one of the most powerful criticisms is someone who observed that if you take patients who took the birth gender questionnaire at the beginning of the study, and instead of waiting till after you've given them cross-sex hormones or puberty blockers, you just immediately gave them the opposite gender questionnaire for them to fill out right afterwards before you did anything, then in all likelihood, you would have produced an improvement of gender dysphoria just by nature of the fact that you're switching the assessment tool that you're using. That observation could have the power to completely delegitimize the claim that it fixed the gender dysphoria anyway. And that's kind of one of the faulty assumptions or the facts that you have to account for that. There's an interview that the Gender a Wider Lens podcast gave with the researchers who implemented that protocol. And they addressed this question of the assessment tool that they used. And they get a hesitant admission that it wasn't the most optimal tool. And then the clinicians go on to say, well, we've developed a new tool that we'll use going forward that's the same for before and after. But the fact that all of these interventions worldwide are being done based on that initial study should raise some red flags when you go back and you realize that this is the nature of how these studies have been implemented. Okay. So thanks for those comments, Ute. Very good stuff. Rembrandt says, I really hope the doctors and parents are held accountable for mutilating these kids. You know, it's tough because it's hard to see. I think both the doctors and the parents are trying to do the right thing. And everybody's in this really difficult spot where you've got kids that are really suffering and doctors that really want to help. They've been given this body of knowledge, this set of assumptions about what the right thing to do is. And there's strong incentives for them to go down that pathway to see what they're doing as the right thing, and then to see anyone who criticizes them as being on the side of the hateful, ignorant, bigots, and the same category as, you know, anti-vaxxers and all other things that are considered on the outs right now. And it really takes some time to dig into really examining the assumptions that you have. If you're a clinician and you're doing these practices, to go back and step back and say, are these things actually justified? And then if you're in this professional environment and you start to question what you're doing, you may find your own professional credentials threatened. And that's why some of these whistleblowers in the UK have been very hesitant to step out of line, because it threatens their livelihood. Or it may embarrass the institution that you're at, because they will then be subject to social media mob embarrassment from trans rights activists who see any dissenting or questioning or critical opinions as a threat to a narrative that they feel necessary to defend. And parents themselves are relying on those medical professionals. And in some cases, once the parents gets to the point where they've taken irreversible step with their kids, there's really strong emotional and psychological reasons for them to double down on that decision, and to see that decision as the right thing, and to vilify anyone who would criticize it. Because if you step back and say, wait a second, it was the wrong thing, then you have to admit that you were complicit in a process that gave irreversible harm to your child. And that's a really hard thing to confront as a parent. There's really strong emotional, psychological reasons for them not to see that. And so parents will probably be among the most strident defenders of this. Leslie North says, I hope it will soon be labeled correctly as female or male genital mutilation. This is something that you'll see critics bring up frequently, and that is that we kind of have laws on the books for genital mutilation. You know, there are some practices associated with certain cultures that involve things like female castration, or things that are characterized as genital mutilation that may be done for religious or cultural purposes that we see as barbaric, or as you know, we've made laws to make them illegal. And so there is a perspective that looks at these medical interventions, which may include removal of secondary and primary sexual characteristics, as a form of genital mutilation. It's hard to wrestle with. I will say that if you're trying to persuade someone who is already very heavily bought into the way of thinking that this is the only option, this is what we have to do, and only bad people don't do it, calling it genital mutilation as your initial foray into the discussion will probably send up walls of defensiveness, and you probably won't make much headway into getting them to see your perspective. You may get there eventually by drawing some distinctions, but it's hard to reach people when you start out with the most inflammatory metaphor. Someone says, it's not an easy issue. If an adult chooses to have surgery, it's really no one's business. However, for a child, it's tricky. I fully support him on blocking hormones, but surgery needs to wait before they can better understand the impacts of surgery. Why are you so worried about what they call someone else's genitals? Do you want permission to say insulting things to people you do not know and talk about other people's genitals? Would you be okay with complete strangers walking up to you and talking about your genitals? They're talking about the procedure, not the genitals themselves. So just basic banter, I guess, on that. Anyway, all right. Well, that's all the commentary there. Before this gets too long, I guess we'll go ahead and close it down. My initial plan for this week was to release each of these documentaries one after the other on each of the day this week in preparation for a new series looking at the witness testimonies in the Ohio State congressional hearings on the question. It's called the SAFE Act. And we'll have a parent of a trans child to give their perspective about how those hearings went and hopefully be able to bring some of what we've learned through this documentary series into the analysis and discussion there. And I think that's going to give us some good insight into what's going on. So we'll see if I can keep this up. We did not have any calls today, which may be due to my clumsy implementation of the timing of all of this, but I just do what I can based on the time that I have available. So we'll go ahead and give one last chance for anyone who is interested and still watching to call in. The number is, hold on. The number is here. 210-422-2222. I'm getting a notice that there is a chance that my browser has blocked the calls, and that's why we haven't heard anything, but I don't think that's the case. Again, the number is 210-422-2222. And I'm getting notices that the video has been blocked on YouTube already, so that's great. I'm pretty sure that it will be unblocked, falling under fair use, and so I'll go through that process. But without any calls, then we will go ahead and close. And so until next time, this has been Talk on Things and Stuff. Bye now.